to people to return. All right, thanks everybody for coming back. Steve, you're back, your team's back. Good, excellent. So before I start, has anyone got any sort of burning questions left over from the previous slides? I'll leave it open for a minute or 30 seconds. So the next half an hour is just a wrap up, really, as well as the annual benchmarking that we do with our colleagues in the benchmarking network. We also do a number of bespoke things. So we're going to go through those products one by one. Some health boards are involved, some are not, but it's something that if you want to see the interest, especially about the stranded patients work that we're currently piloting with Betsy, then get in contact with myself and we can see. One of the things that I've been having a few emails around about is this deep dive, this benchmarking. So we might pick one health board in the new year once we get over this Christmas and maybe try and bring all the data points together to see if it starts to develop into a model and maybe some of the experience stuff, the proms and the prems as well. So we might do that. I'd like to start on AB. I'll contact Michelle and Chris O'Connor, and that might be a good place to start. As we can see, that model seems slightly different from other parts in Wales, and that might point to some other data that we have or haven't got. So we'll see. So some of the benchmarking, we're going to split this up, I think, across your team, Steve. So over to you to tell us some of the bespoke benchmarking.
Thanks, Shane. We've got a three-way presentation, really, with Kirsten, Ellie and Bev. So we're going to look at eating disorders, we look at the COVID modelling work, and then we'll introduce the long-stay complex stranded patients. So I think first up is Ellie Gosling, who's going to run these slides and talk to them. Yeah.
Hi everyone. So yes, as Steve said, I'm going to start us off talking about these bespoke pieces. And the one that I'm going to talk to you about this morning is around the demand and capacity modelling tool. So let me start with that. So I've just taken a few screenshots here. You'll see over the following slides. Previously, in the last event earlier in the year, we did a demonstration of the tool, and we're more than happy to do that with anyone who isn't overly familiar. But what we've tried to do today is just summarise what's in the tool, what you can do with it in terms of existing data, what you can do in terms of modelling, and where we go from here. So in terms of the latest version of the tool, so this will be released alongside the outputs from today's sessions, as Shane said, within the next 24 hours or so. And this current version of the tool, the new improved version, will take us all the way up to September 2021. So one of the key factors about the COVID reporting is that the outputs are really timely. So the fact that this tool will take us up to just September 2021, we're now in early December, hopefully that's really useful for you as health boards. And a big thank you to, I know I speak to you, a lot of you on a very regular basis in terms of getting your data to us. So before we go any further, just a big thank you for getting that over to us every month. And what we do with that data is we populate it all into this snazzy tool, and it covers adult mental health, CAMHS and learning disabilities sections. So I know we're in the adult mental health section this morning, but just to flag that it does cover those different sections as well within the tool. In addition to all the charts and modelling elements, there's also a focus this time around on the literature review. And we've been collaborating quite a lot with NHS Wales to try and ascertain the breadth really of this literature that's now available. We did have this within earlier modelling tools, but this time around it's far more comprehensive. We've organised it by themes. There's obviously a lot more that's come out since the first iteration of this tool came out to you. So going back to that previous slide, you can see on that opening page, there's a link there to the literature review, so you can easily access that via the tool itself. We look within this literature review at specific Wales publications, and in addition to that, we also look around the wider UK. So, but it's very much Wales centric, and as the tool, it covers CAMHS, adult mental health, and it also looks at psychological therapies as well. So our colleague Jack isn't with us today, but what he's done here is summarise some of the key points that come out of the Lit Review this time around, covering adult mental health, CAMHS, primary care psychological therapies and workforce. So he's noted a few of the sources there and the key trends, but you can look at that in more detail within the tool itself. I think it's a really comprehensive review, and if having read it, you've got any thoughts on what we can include moving forward, that would be really interesting. And we'll be updating this as we go through. So this tool takes up to September 21. The next one will take us up to the end of December, so that will be out next spring, and we'll be updating that with more literature as it comes out. So just a quick look at the tool itself. So I've tried to just do a few simplistic screenshots here of what you can do with it, for those of you who may not be overly familiar with the tool. And what you can do is you can see comparisons, not only where you sit as a health board within the monthly UK data set, but you can just look at Wales. And I'll show you a couple of those screenshots on the following slide. You can easily navigate between the different sections, so adults, CAMHS, and learning disabilities as well. And then the bottom screenshot shows sort of the different drop downs that we have available. So those of you who are familiar with our mental health toolkit, it's a similar structure in terms of the range of drop downs available. So we have a range of different metrics, so looking at bed occupancy, admission numbers, beds open as on the snapshot date, and you can view that both at raw data level, so just the data before we apply any benchmarks, and then also adding population benchmarks for some of the others as a percentage of total contacts, for example. So there are numerous different benchmarks that can be applied depending on which metric you're looking at. To the left-hand side there, you can see the different viewpoints. So as I said, you can look at UK or Wales, so you can see the different views of those, and then you can also toggle between the months. So the latest month is September 21, but you can go all the way back to April 2020 and view those at a monthly level using that button there. So these are examples of what the charts look like, and you can see here that we've just focused on adult bed occupancy. So you've got the health boards identified within that national data set, so UK wide, and then you can also look at just Wales only, which is that right hand one, and see how that reflects on the map. So the same controls that we used previously, but it's just an example of what you'd expect to see within those sections. So in addition to the charts that sort of show where we are now, where we have been previously, there's also the really important modelling elements of the tool, where we look at, based on the data that we've had through, where might we be in 3 months' time, in 6 months' time. As with other elements of the tool, you can look at this in terms of what your health board is doing. So you'll see Iron Bevan's highlighted there, and you can also look at it Wales wide. So in terms of the totality of the health boards and where that places you. I've highlighted the different modelling buttons there in the screenshot, so you can see that we have inpatient modelling tools available, and then we also base some projections around the community data as well. So this screenshot here, I won't go into too much detail today, but it shows at a health board level and at Wales wide level what we would be expecting to happen given the data that you provided to us each month. So some of this data is drawn from pre-COVID submission data, so data that your health board may have submitted as part of the 2019-20 annual work. And then what we try and do is draw in your COVID monthly data to ascertain where that might leave you based on current demand, 90% of normal levels, etc., and that can all be amended in that top button that I've highlighted. So it's a really interactive tool. What we want to try and do is make it as user friendly as possible, so that you can change the time period, you can change where you would expect to be, and then you can see the corresponding data table to the right of that. So we chart it on the left, and and then display the data in the right. And there's numerous different options there. So we have option 1, option 2, and as I said, it covers inpatient and community data. And we've got some modelling elements within the CAMS section as well. So I know that the latest version of the tool is due to be released alongside the outputs from this event, so that'll be with you very shortly. And those modelling assumptions take us up, you can see, to March 2022. So a lot of data there to play with, but hopefully it will be a useful tool for you moving forward. So that's the modelling tool. I'm now going to pass you over to my colleague Kirsten, who's going to tell you a little bit more about the eating disorder census and where we're up to with that.
Hi, thank you, Ellie. So the next few slides are just going to show some highlights from our recent eating disorder census that we carried out in June of this year to understand the demand for inpatient eating disorders and community services. So in the UK, approximately 1.25 million people have a diagnosable or estimated to have a diagnosable eating disorder. Yet eating disorder services share the biggest gap between service delivery and population needs and morbidity. So the study looked at trends over the last 3-4 years in terms of inpatient care and community care, as well as a bespoke census. So for inpatients, that looked at a particular census date on the 30th of June to understand inpatient numbers and patient acuity on that date. And that was alongside a community census carried out throughout the month of June, where we assessed demand for community services. Next slide, please, Ellie. If I just talk you through some highlights in terms of trends for inpatients over the last 3 to 4 years, we saw an increase of over 20% since 2018, and the majority of that increase happened in the most recent year. And that 22% increase translates into, in terms of numbers, translates into just under 160 new patients accessing services during that time. In terms of the largest number of people accessing inpatient care, it's in the over 18s. But what we did see was the largest increase in numbers and demand happening in the under 16s. If we just take a quick look at on the right-hand side of your screen, you'll see a graph showing monthly eating disorder admissions, and that starts from January 2020, just after the pandemic started. And what we can see is quite a lot of variability in the terms of demand for inpatient care. In particular, the first peak happening in July, August time, between the two, the first UK lockdown and the regional Wales lockdowns, with the second peak happening in about November 2020 after the Wales regional lockdown happened. So we can see quite a lot of increase in demand during that period of time. Just to talk you through some of the highlights from the community trends analysis, we saw relative stability in terms of referrals and caseloads. In terms of average numbers on caseloads, that came in at about 39 patients per health board, and in terms of referral numbers, that was around 54 per health board. In terms of conversion rates, so there was about 75% of people who accessed or who were referred to services were able to access services and taken onto caseloads. If we now move to the left-hand side of the slide, those are some graphs that reflect some of the highlights from the census, the bespoke census, inpatient and community census that we carried out. If I start with the inpatient census, that covered all 6 health boards as well as 2 private providers, and we identified 30 patients in inpatient care on the 30th of June. The majority were female, and the majority were also young, so under age of 16, and in fact over a third were young and female. Ethnicity was quite poorly recorded. In fact, white was the only ethnicity recorded, and that represented 83% of patients. So just in the context of Stu's earlier narrative around ethnicity and recording of ethnicity, that we weren't able to properly investigate that in terms of the data. About half of patients were currently subject to the Mental Health Act detention. And what we saw was a pattern of decreasing detention with increasing age. So it tended to be younger patients who were detained. If we look at that top bar chart on the left, that's predominantly orange and blue. That represents eating disorder diagnosis by age band. And we can see for the under 16, so 0 to 15 years of age, we can see that a greater number had a diagnosis of avoidant restrictive eating disorder. And that pattern shifted in the older age group. So if you look at that age group in the far right-hand bar, the 19 and overs, diagnosis was predominantly anorexia nervosa. And what this might suggest is a progression in acuity of eating disorders, or perhaps more confidence in diagnosing anorexia nervosa in older patients. If we move on to some key highlights from the community census that took place across the month of June. In the trends data, we saw an average caseload of 39. However, in this census, there was actually an increase in the average number of patients on caseloads. So there was 46 on average on caseloads. If we look at the bar chart to the far left-hand side, at the bottom, the one with the red and blue columns, the blue bars represent total number of patients on caseload, and the red is the number of these patients who had a clinical contact. And that black line up top shows the percentage of individuals who received clinical contact in month. And what we can see there is that among adults, a very high proportion of adults received clinical contact in month, just under 90%, and that pattern was similar across younger patients as well. So we saw nearly 90% of young people and adults seen in month. So the Welsh position is actually favourable in comparison to the UK. So when we looked at the wider UK reporting, only 53% of patients on caseload had received clinical contact in month. So those are just some very quick highlights of the June census. We're in the middle of carrying out a second census as well, and those findings will be shared in due course. I'll just pass you over to Bev.
Yeah, good morning. As both Steve and Carrie this morning have alluded to, we are looking at long stay patients as being something that we need to focus on in terms of looking at mental health in patients. The graphic in front of you at the moment is showing complex or stranded patients or long stay patients, however you want to describe them, over 60 days. So the persons in grey represent the patients staying less than 60 days. The blue are staying 60 to 89 days, and the red 90 days plus. On the left, you've got the number of people representing admissions or discharges, and on the right we're representing the same colours representing occupied bed days. Steve mentioned this morning that in the 90-day plus category, 7% of patients represent 39% of occupied bed days across the UK wide. And in the little boxes below, I've put the Welsh position, so you can see that a smaller percentage of patients represent a greater percentage of the occupied bed days in Wales. So when you look at the combined position, again, you've got when you look at 60 days plus, it's 14% of patients represent 53% of occupied bed days in the UK, whereas in Wales, it's 9% of patients representing 55% of bed days. Go to the next slide, please, Ellie. So what this slide is doing is plotting each of the providers, including the Wales boards, which I've labelled at the bottom there. And what we're doing here is showing the percentage of bed days by length of stay band. So we have 5 bands here. So when you look at the yellow is 0 to 3 days, the red 4 to 13, the green 14 to 59 days, and then the purple 60 to 89, and the blue the 90 days plus. And how we've sorted it is on the left side of the chart. You can see the boards and trusts on the left are more exposed to the long stay patients. So you're looking at the Wales, the 3 Welsh boards there, probably in the highest quartile for the highest exposure to long stay patients. Whereas you also have on the far right one of the boards with perhaps one of the smallest exposures to long stay patients. And this sort of reinforces, I think, some of the slides that Steve was showing this morning in the variability that we see across Wales in length of stay being recorded. I should say this is for adult acute mental health patients specifically. Next slide, please, Ellie. So what we're doing is we have done with a number of our members across England is to do a deep dive of these complex patients, typically focusing on those patients staying longer than 90 days. And what we're trying to do is work out if there are themes in the characteristics of those patients. So we are looking at their diagnoses in terms of the mental health diagnoses, their primary, secondary and tertiary diagnoses. We're looking at their age, their gender and ethnicity profiles. And again, hopefully we can start to capture some of that ethnicity details a bit more completely than we have in the previous year's data. We're looking at admission and discharge details. For example, in terms of discharge, we're looking at where those patients are being discharged to and whether they had a recorded delay in discharge. We're also looking at their chronic physical health conditions such as diabetes, cardiovascular, respiratory, neurological, a number of other chronic conditions that again may be impacting their stay in hospital. We're also determining whether they had learning difficulties or autism. And we're looking at their clinical history with the mental health service, whether they had previous admissions, whether they're known to community teams, and whether they've previously been detained. And once we get all that information, we're hoping to determine whether there are key characteristics of that cohort of patients that stay beyond 90 days. And what we're able to do, having done this with a number of other providers across England in the northeast, the northwest and the southwest, is we'll be able to compare the Wales position to those other providers to see whether there are consistent themes across all organisations or whether Wales is different. And what we're hoping to do is to help the health boards then identify where there are opportunities to reduce long stay. And as again, the next steps are we've undertaken a number of these across England, and we're going to do one with Wales. We're delighted that Betsy are the pilot site, and we've just started this with them, and hopefully we're going to get their data in the next couple of weeks. So hopefully by the end of January, early February, we'll be in a position to report back. And then hopefully, depending on how that goes and following an evaluation of that project, that pilot project, we'll hopefully be able to roll this out with other Welsh boards. Thank you very much. Back to you, Shane.
Thank you very much. So just some thanks behind that. One, just to recognise there's an awful lot of work going behind all those tools. So the NCCU obviously support benchmarking, but also the health boards are involved. So on the demand tool, we spent many months developing that tool. It's what the health boards asked for. So if you haven't seen it and haven't used it, please do so. On the demand and capacity, if you're not familiar with the use of demand and capacity tools, my colleagues in the delivery unit have been going around to targeted, or for people who want to request it, to show you how you can use those tools to start plotting around what's coming over the horizon for your particular service. For the eating disorder census, we should be able to do the second report. So we did a census in June. We've just done another one a few weeks ago. So in about a week or so, we will produce the second report on this to see whether there's been an increased trend and where that trend has been in Wales. So my thanks again to the DU and to the Eating Disorder Network, Menna, who's with us today, for their help and support. That was a census of all medical wards across Wales, so that was quite difficult to get out and about, but we managed to do it. So again, my thanks to them. On the stranded patients, as Bev just said, we're Betsy have come forward as a pilot. It's a lot about a data and collect it, so we're working out how we do it yet. But again, if anybody in February, when we release it, I might pull a meeting together, and everyone wants to do that in their local service, and we think it's a useful exercise, then we can show you those results and you can come forward. But again, there's a lot of work there. My particular thanks to the Welsh Government, who fund the NCCU to do a lot of this work and benchmarking. So my thanks for that. We all crawl over the data, and some of this data has actually benefited in terms of the 42 million. So some of the benchmarking data and some of the eating disorder benchmarking was used in the financial settlement by the Welsh Government to get additional funding for mental health. That's how important it is. So, you know, we've got an additional 42 based partially on some of the data you've discussed today and try and describe the pressure that our system is under in mental health. So it's really important that this data is used. One of my requests is, you probably would have seen some of the slides that not all the health boards can produce some of the data. Some of them it's 5, some of it's 6 health boards. So one thing from me is when we launch the All Wales benchmarking report in the next 24 hours is to look at that and ask that question internally in the health board is why couldn't we answer that? If you see a health board that's next to you that could answer that question or could submit that data, it'd be really good to say, well, I wonder how they did it. Maybe it's your technical infrastructure, your architecture of data, but it is so important that we get the maximum number of health boards submitting consistent data across. And some, it does appear in Wales that some may be slightly better at submitting that data than others. So do have a look at that and see. So final report for me is just to say thank you all for coming. Thank you so much for Steve and all the benchmarking team. I find these absolutely fascinating. And hopefully all the health boards also find that fascinating. We're always here to help you. So if anyone's got any questions or queries, that's fine. As I said before, we'll probably think around doing a deep dive in one health board and bringing all that data together. All of the stuff you've seen today, including the All Wales report, the benchmarking tool, the recording from the event and the slide set will be available on the NCCU website, and you can share that link. It's been shared a couple of times, so that will all be available from 9 o'clock tomorrow morning. So last from me is just thank you all for attending. I will pause for a second if there's any questions from anybody, or you're stunned into data silence. There has been a lot today, but please take it away. I know you're all busy over winter, but I don't think personally there's a better time to try and understand not only what we've done and the journey that you've all been for over the last year, but really what's the next stage and what's the next sort of 6 months bring to us. So please use the data and the tools as much as you can in your health board. So thank you very much. We'll reconvene at 2 o'clock today for those that also manage or are interested in the CAMs. And thank you, Steve, and your team. Thank you all.
Thank you, everyone.